Today we're going to be talking about cardiovascular disease, which is a group of different disorders. Today we're going to be talking about coronary heart disease, stroke, and heart failure, and some peripheral arterial disease as well. So there's a bunch of different ways that this can happen, but the treatment for cardiovascular disease is pretty similar, and the prevention has a lot of the same risk factors involved. So why is this important? So we know cardiovascular disease is the leading cause of death in the United States for both men and women. So that's a pretty good reason, but recently it's also been expanded to the world. So we could probably save a lot of lives from the information in this video. That's my personal bias because I'm a student physical therapist. So I know that physical activity can prevent disease, and it can also restore lost function once you already have the disease. But this is not the only intervention for these diseases. It's just one of the diseases that I'm informed about, or one of the ways we can impact the diseases. So heart failure is essentially when you have a muscle dysfunction in your heart, so that when you have a demand in your body, your heart can't meet that demand by providing supply through ejection of blood. And this can happen a couple different ways. So left-sided heart failure is your left ventricle pumps blood to your body, and when that is dysfunctional, it causes blood to back up and into your left atrium, which backs up fluid in your lungs, and this can cause issues with breathing, and you could have a cough, right? And then right-sided heart failure can cause fluid to back up into the venous system or your veins, and this can cause just general swelling all over your body. And then systolic dysfunction is essentially when you have a decreased ejection fraction. So that means that the amount of blood that's pushed out of your heart, the percentage of the volume in your heart, is less than normal, and that can cause issues with cardiac output and different kinds of things. And then there's also diastolic dysfunction, which there's less blood total, but the ejection fraction is preserved. You don't really need to know that, but that's heart failure, right? And then we have coronary artery disease, and this is part of the circulation in your heart is supplied by its own arteries. So the coronary arteries supply your heart with blood, and they can become blocked or constricted over time with a buildup of fatty plaques. And this actually starts happening pretty early on in the life cycle. I think some teenagers have fatty streaks, and those are, you build on that with things like LDL or total cholesterol combined with fibrin or fibrous tissue. They create these plaques that reduce the diameter of your arteries, and this is called atherosclerosis. And this is important because as we age and as these plaques get larger and larger, this narrowing can reduce the blood flow to your heart, and this produces what's called ischemia. And ischemia is just a fancy way to say there's not enough oxygen getting to the heart muscle. And this is a problem because if this happens, these heart muscle cells, cardiomyocytes, can die off. This can be deadly. This can cause things like myocardial infarctions or heart attacks. So definitely something we want to pay attention to. Then we have peripheral arterial disease, and this is very similar to coronary artery disease, except these arteries supply things like our feet and our arms. So these are the same fatty deposits in the arterial walls. And you'll find with PAD, or peripheral artery disease, you could have an ankle brachial index. So what this means is the ratio between your blood pressure in your feet and the blood pressure in your arm is less than 0.9. And it can get way worse than that, but that's kind of indicative of beginning to have arterial disease. And this is important because it reduces blood flow to your feet, and this can reduce sensation. It can cause things like ulcers and wounds. And a common symptom of PAD is intermittent claudication. And what this means is when you're walking, you'll have basically a pull, or it might be painful in your calf muscle. That's because when you're walking, that calf muscle is demanding oxygen. But when that arterial or the artery is blocked, it's going to reduce blood flow to that calf muscle, and you're going to have ischemia of the calf muscle. And this can actually be improved with exercise interventions, which we'll talk about later. And then we have peripheral vascular disease. So we have arteries, which generally push blood away from the heart to the body. The only difference is like the pulmonary artery, which we're not concerned about right now. But the peripheral vascular disease is affecting the vasculature. So these are veins that pull blood or fluid from the extremity back to the heart through the right atrium. But when we have disorder of the veins, we're going to have a reduced return of that fluid. And so what this will cause is basically general swelling, edema, which is swelling, and this can lead to insufficiency of the valves in your veins, and it's just not great perfusion of your body. And this can be kind of impacted with a muscle pump. And so what's cool about your muscles is there's little veins that run through them. So when they contract, the muscle belly gets wider, and this can squeeze the veins. And veins usually have one-way valves, so the only direction blood can move is to your heart. Though these valves can become insufficient, but the muscle pump action can actually help with return of fluid, and that's something physical therapy can work with. And having PVD is important because it can increase the risk of a heart attack or a stroke by upwards of 4 to 5 times. And this is because when you have static blood, you're at risk for developing things like clots and pulmonary embolisms, which is a different topic. And then we have hypertension, which you're probably all familiar with. It's essentially abnormally high blood pressure that's due to restricted flow due to like a narrowed vessel. And this can happen a couple different ways. It can be constricted, or you can have a way too high blood volume, or your heart rate can be high, way too high. And it's defined as a systolic blood pressure. So systole is the pressure in your arteries when your heart is contracting. And so this is going to be higher. So anything over 140 millimeters of mercury is considered hypertension. And a diastolic blood pressure of over 90 millimeters of mercury is considered hypertension. So diastolic is when your heart is relaxed. What's the pressure in the arteries? And the risk factors for hypertension are things like smoking, obesity, diet, drugs, stress, dyslipidemia or hyperlipidemia, inactivity, and genetics. And what's cool about, well, it's not cool, but primary prevention, so this is before you develop the disease, can have a huge impact on these risk factors. So if you do everything right from birth, you might be able to avoid the development of hypertension and hopefully reduce the risk of developing things like cardiovascular disease in the long run. And so we have myocardial infarction, also known as heart attacks. And your heart requires blood, oxygen, to beat. And in myocardial infarction, the heart muscle demands way too much blood than can be supplied by the coronary vessels. And this deficit can cause heart cell death. This can cause chest pain, also known as angina, and radiating pain down the arms, jaw pain. And because of this risk of myocardial infarction, exercise should be kept under an intensity that triggers angina or those symptoms we just discussed, because it can put you at risk for ischemia or myocardial infarction, which we do not want. So we have many risk factors. Some of them are modifiable, some of them are not modifiable. But if we know these, we can prevent or help prevent the disease from developing in the first place. So we have age, not very preventable, but as we get older, so over 45 and older for men and over 55 and older for women, we are at an increased risk for cardiovascular disease. And family history, so if you have a first degree relative that's male who has died before the age of 55 in fathers or 65 in mothers, that can put you at an increased risk. But what's interesting about this is you have to kind of do a deep dive into their life and see if they were obese, if they were inactive. All of these things kind of increase your risk. That might not necessarily be genetic. It could just be the way their life played out. And then we have smoking. Smoking is very modifiable, but there's a lot of psychology, and smoking cessation is a big topic that can help a lot of people, because smoking is up there with the most if all people smoked, it would do, or if all people did not smoke, it would prevent a lot of disease. So we have being sedentary, and this is defined as not performing 30 minutes of moderate intensity exercise 3 days a week over the last 3 months. And this is, easy, low-hanging fruit. So just move more, right? And this can reduce our risk. Then we have obesity, and we have BMI, and this is kilograms and just your height and weight, essentially. So anything over 30 is going to be considered obese. Though if you have a lot of lean mass, like I do, like as a bodybuilder, we have artificially high BMIs, and it's not necessarily the same as having a fat mass that's excessive. But waist of greater than 40 inches for men and greater than 35 inches for women is also predicted, or you could use that instead, or with the BMI measurement. Then hypertension, as we discussed, 140 systolic, 90 diastolic. And just to give you a sense of the magnitude of how important this is, in individuals between 40 and 70 years of age, an increase of 20 millimeters of mercury of systolic blood pressure and 10 millimeters of mercury of diastolic blood pressure doubles the risk of cardiovascular disease. So that is an incredibly high effect size. So we should definitely be looking at blood pressure. Dyslipidemia. So dis is bad, lipid is fat. So this means that the circulating lipids in your blood are out of control. So we have cholesterol over 200 milligrams per deciliter, LDL over 130 milligrams per deciliter, and HDL under 40 milligrams per deciliter. These all contribute to an increased risk for cardiovascular disease. And what's interesting is that high density lipoprotein, that's HDL, above 60 is considered protective for cardiovascular disease. And dyslipidemia is somewhat genetic, but it also has a dietary factor. It has an exercise correlation. So it's definitely modifiable. And if you're medically complex, there's a lot of things that physicians and I guess pharmacologists can do with medication to control dyslipidemia or hypertension, right? Like exercise is not the only intervention. I'm not going to pretend it is, but yeah, dyslipidemia is an important piece because that LDL cholesterol is what helps lay down that plaque in your arteries. So if we have increased LDL and cholesterol, we're going to have an increased risk of laying down that plaque, which we do not want if you don't want to have a myocardial infarction, right? So diabetes, also risk factor. So this is basically just issues controlling blood glucose. So this would be like if you're fasting for 8 hours and they draw your blood, you have a glucose level of above 126 milligrams deciliter and an elevated hemoglobin A1C, over 6.5. They're all signs that you could be having issues controlling blood glucose. We actually did a podcast last week over diabetes, so you can go ahead and listen to that if you would like more information. So now we get to prevention of these risk factors. So we have primary prevention, and so I'm just going to say a few of the cool effects that we can have with primary prevention with exercise. So reducing the risk of disease before the disease develops. So exercise can lower blood pressure. It can reduce the progress of hypertension. And this is great news because it reduces. So hypertension is putting more stress on the heart, because if you put more pressure through the system, the heart has to contract against that pressure, and it's more workload. And if you have more workload, you need more blood, and if you have a poor supply of blood, you create ischemia. So reducing hypertension with exercise is a way we can attack that cardiovascular disease. And a decrease in heart rate and blood pressure is found with trained individuals. So this is because you get more efficient with an increase of fitness. So you don't, at rest, you're going to have a lower heart rate if you're cardiovascularly fit, and you can do that with aerobic exercise, which is pretty neat. So aerobic exercise also improves things like VO2 max, stroke volume, and these are the ways that we have that lower heart rate. Sedentary living can increase your risk. So if we're more active, so for instance, we could spend 2 hours spent on a screen, right? And that would increase our risk of developing cardiovascular disease by 17%. And during bed rest, reduced activity showed dysfunction in the veins, increased blood pressure, and narrowing of the arteries. So I think you get the point. So we have secondary prevention. And this is after you get you have some chest pain and you feel faint and you feel that jaw pain. You go to the doctor, they're like, hey, you have a myocardial infarction, and they give you medication. And now what do we do? So we want to make you as healthy as possible and as functional as possible. And one of my favorite organizations, the American College of Sports Medicine, they're excellent. They have this saying, exercise is medicine. And it really is, because physical activity can prevent and treat chronic diseases such as heart disease. And this is because those at risk for myocardial infarction with exercise have seen to decrease inflammatory markers such as CRP, and decrease stress and damage on the coronary arteries, and increase new blood vessels, this is angiogenesis. So when you have that blockage in your heart, what can happen is your body is smart. So it's like, hey, we don't have enough oxygen to supply this part of the heart. And so angiogenesis is just new vessel. So you're going to try to bridge over and supply that part of the heart tissue with a new vessel. And this can prevent myocardial infarction if you're lucky. But that's something that exercise can do, is it stimulates angiogenesis, or the creation of new blood vessels, which can also help recovery from MI. And so for the treatment of this cardiovascular disease, we have cardiac rehabilitation, so that would be like physical therapy, exercise physiology, medications, diet, surgery, and stress management, right? So anything that's going to increase that workload on the heart, we're going to want to avoid while we recover. And regular exercise can decrease risk of clotting and reduce the risk of a second myocardial infarction, and improve the quality of life for those. So there's ways we can measure or quality of life in the hospital, and exercise has just been shown to improve that. So, we all want to have a better quality of life. So this is some things that exercise can do. Exercise has also been shown to reduce blood pressure and reverse atherosclerotic plaques. So super highly potent intervention that we have at our fingertips. So how do we actually go about doing it? And I would say, if you are a patient, do not listen to me, listen to your healthcare provider. But just going into some of the principles of what we would do if we had a patient, but I'm not licensed, so do not listen to me. This is just for educational purposes only, right? So we have aerobic exercise. So this is exercise that's rhythmic. If you're using large muscle groups over a long period of time, hopefully. So endurance exercise, it's potent because it can lower resting systolic blood pressure and diastolic blood pressure by 5 to 7 millimeters of mercury and delay hypertension progression. So again, we're just reducing the workload on the heart so that we are at a reduced risk of ischemia. So the purpose, as I just said, it is all those things. It improves quality of life and efficiency, and it can actually reduce the amount of hospital stays, days in the hospital. So people who are aerobically trained and go through cardiac rehab have a less risk of chance of mortality. So you have a better opportunity to live, essentially. So the frequency of aerobic exercise is daily, preferably, or 3 to 7 days a week for cardiovascular disease. And then the intensity level really depends on how deconditioned the patient would be. So a moderate rating of perceived exertion would be 11 to 14 out of 20, or 30 to 39% heart rate reserve, or 20 to 30 beats above resting heart rate. And intensity should be kept below a level where you have that ischemia, you have that chest pain, because we don't want to stimulate damage and we don't want to improve or increase the risk for myocardial infarction. And because we are at risk for these kind of things, we want to implement a warm-up and a cool-down, basically just to gradually get that heart warmed up, improve blood flow, and then gradually decrease heart rate. So if your heart rate is like 160 beats per minute, which would be a lot for especially someone who is at risk, we wouldn't want to be that high anyways. But when you reduce, so when you come off of an aerobic exercise bout, so you just finish a run, you don't want to just go from running 6 to 8 miles an hour to like standing still, because your heart rate's going to tank. So you want to, instead of like just stopping completely, you want to just walk and slowly reduce the intensity level that you're demanding on your heart, so that you have that gradual return back to baseline. And time. So how long should we be running or rowing or whatever we choose to do aerobic exercise? So it's been shown that 20 to 60 minutes per session would be fantastic, but if you are a low-fit individual, highly symptomatic at risk, we might start with just 1 to 5 minutes and progress to 10 to 15 minutes. And then we might repeat 10 to 15 minutes 2 to 3 times a day. So we're getting, in total, 20 to 60 minutes per session. And if we have something called peripheral arterial disease, so we have that claudication in our calf muscle, we might begin with 15 minutes total, progress 5 minutes every week, so that we're getting more and more stimulus over time. And if we're a healthy individual, the ACSM's goal for everybody is 150 minutes a week at a moderate intensity, or 75 minutes a week of vigorous intensity. And that's kind of the number that you want to hit if you're just trying to do primary prevention as a healthy person. Or that's what we want to return people to after they have an event, if it's feasible and safe. So high intensity interval exercise HIIT training is pretty cool, because it can do a lot of, so basically what it is you would do a 1 to 5 minute work set at pretty high intensity, above 90% VO2 max, and then 1 to 5 minutes of active rest. And then you would do that for 35 minutes total. So it's pretty cool because if you have a stable heart failure and you can kind of keep that under symptom producing thresholds, you can improve VO2 max, decrease the risk of mortality, and just improve daily function and strength in a very short amount of time. So it's very efficient, but especially for people at risk, it might be too much. But it's an option. And then we have resistance training. And so these are things like elastic bands, light dumbbells, and machines. And the purpose here, it can actually improve aerobic capacity, especially if you're very deconditioned. It can improve the 6-minute walk test. And so that's essentially the amount of distance you can walk in a 6-minute time period. Quality of life and strength, obviously. So if you're in bed, you are actively being atrophied because you're not moving, which can happen very quickly, especially if you are not stimulating your bones and muscles through movement, you're going to atrophy. So resistance training is incredibly important to keep the integrity of your muscles and bones, essentially just strong enough to support your life after discharge. So the frequency we would do is like 2 to 4 days a week, and intensity level here would be 60 to 80% of your 1 rep max, and we would be doing 8 to 12 exercises, 1 to 4 sets per exercise, or 45 to 60 minutes per session, depending on your tolerance. And we would not want to do things like heavy deadlifts or anything that's going to spike your blood pressure. So try to imagine you're picking up like a 80-pound box. What would you do? You would kind of contract your core, you would contract your throat. That's called a valsalva, and that can spike blood pressure in your brain and your arteries everywhere. And if you're at risk, that can be at risk for an acute myocardial infarction or things like strokes because you have hypertension. We would want to avoid that spiking of blood pressure. So relatively lower intensities for resistance training. And so we should combine these two things. So we have aerobic training and we have resistance training. And by combining them, we could improve strength, endurance, quality of life, and it's been shown that combination is better than aerobics alone. And then we have flexibility training. So inactivity after hospitalization can lead to stiff joints, shortened muscles, because if we're not moving, we can develop things called contractures, which nasty little things can basically just get you stuck in a position which we do not want. So we want to stretch all major joints, so like your knee and your shoulder, 15 to 30 seconds for 2 to 4 repetitions can help preserve the function of your mobility. And we can do things like inspiratory muscle training, I guess we could, or neuromuscular electrical stimulation are some modalities that we can use in the hospital to help patients essentially. And then some precautions. So after a event, you're usually admitted or hopefully admitted to a hospital. And then you would have a cardiac rehabilitation program there. And that requires medical stability. And the medical team would run things like troponins and creatinine and liver function, blood testing, hemoglobin. All of those things would be considered. And you would then be released for cardiac rehabilitation program inside of the hospital. And so that would then have you work on things like sitting up from the bed and building postural and positional tolerance, because you're kind of just at a fragile state and you wouldn't want to independently go off on your own and run a marathon, right? Because these things need to happen in controlled doses. So after discharge from the hospital, you would go to an outpatient facility and you would be monitored by a professional with an EKG. So this would look for dysarrhythmias and exercise intolerance, and then the professional could get you help or adjust the exercise prescription. And so with progress, they take the EKG off, you're basically just being supervised. And then after that stage, you go independently into the community. Congratulations. You can do your own cardiovascular and exercise on your own. So you're stable. So in the presence of cardiac arrhythmias, comorbidities like diabetes, essentially it impacts the level and intensity that you can exercise, and ignoring the cardiac signs like chest pain can result in cardiac events and death. So we definitely don't want to ignore those things. So orthostatic hypotension is essentially a positional intolerance and blood pressure. So you can imagine just sitting up from a chair, sitting to standing, and that would decrease your blood pressure by 20 millimeters of mercury systolic or 10 millimeters of mercury diastolic. This can cause a change in blood pressure caused by a positional change. So this can cause things like dizziness, confusion, and fainting. So this is why if you're medically complex, you need to be supervised, because these things can happen and you would want assistance if that were to happen. And exercising can actually do a lot of things physiologically. So we would monitor things like heart rate. If it decreases by 10 beats per minute, you're not responding in a typical way, so we should stop exercising. If your systolic blood pressure decreases by 10, that's also a problem. Or if it's above 220 millimeters of mercury, that's a problem, because it could lead to things like stroke or hemorrhages, right? So we would not want to continue exercise if your blood pressure is way too high. And if your SpO2, so those are things that are monitored by little clip-ons on your finger, and that's basically just the saturation of oxygen. The hemoglobin, what's the saturation? 90%. If it's below that, you definitely want to stop exercising, because that could lead to hypoxia. And then chest pain, right? So stable chest pain is pain that's predictable based on a workload. So how much systolic blood pressure you have and how much heart rate you have, that's a demand on your heart. And if it's stable, then healthcare providers can give you a prescription that is safe. But if it's unstable, so if you have symptoms at rest for heart pain, that is a medical emergency. So you should not exercise. And wheezing and chest tightness, you should go see a medical doctor. So do not begin exercise if you have systolic blood pressure over 180 millimeters of mercury or diastolic blood pressure over 110 millimeters of mercury. You must be cleared by a healthcare provider, and typically they'll give you a medication to lower that blood pressure so that you're safe for exercise. And then you have heart rate under 50 beats per minute or 100 or over 140 beats per minute at rest is also not great. You should not exercise if you have cold sweats or shortness of breath that's not been checked off, and unstable chest pain, onset of a new or worsening cardiac arrhythmia. So this could be things like, AFib or atrial fibrillation or ventricular fibrillation, which are things that you should get medically controlled. Onset of an S30 heart sound, and the only way you would know that is if someone had listened to your heart. And if you require to sleep by sitting in a chair, that's a sign that you have issues regulating your blood pressure. Or if you have gained weight more than 5 pounds in 3 days, that could be indicative of heart failure. So yeah, that is how exercise can impact cardiovascular disease, and I hope you've learned something. It's definitely super interesting, especially because just the prevalence of cardiovascular disease, especially in our society, being inactive, obese, things like diet and exercise, just doing the basics correctly could do a lot of good in terms of primary prevention, and once you've had an event, secondary prevention. So yeah, hopefully you enjoyed it. Let me know what you learned in the comments, and I'll see you all in the next one. Peace.